Hello everyone, Professor Mohammed Subhi.
فكر طبعا ده هو اللي بيغذينا ده.
Mohammed.
Hello. Hello, Habib. Hello, Habib.
Welcome again. We are honored and pleased to have you with us, with your team from the ICC Alexandria, Egypt. And I would like to also welcome eminent panelist with us, Adel Etribi, that you certainly not know. He's from Cairo, Ziad Ghazel from Beirut, Qais Batih from Djerba, Tunisia, Nazim Maghribi from Algeria, and Awad Mohammed from Khartoum, Sudan. I will ask Adel Etribi to take the lead of the moderation of this session. Adel, go ahead.
Adel, unmute yourself, Adel.
You're on mute.
I'm sorry. Thank you, Habib, for inviting me to chair this important session. And it gives me a great pleasure to be chairing a session where live transmission is done by my dear friend Mohammed Subhi from the ICC. The ICC Center is one of the very active private centers in Egypt, in Alexandria, of course, and in Egypt. And I hope it will be a teaching case. Could you please, Mohammed, tell us what's the case and what?
Yeah. First of all, good evening, everybody. Bani Habib and all the course directors of Pafcic 2020 and my friends Adel Etribi, Ziad, Batih, and everybody here. And Awad is going to do a lecture after this. It's an honor with me to have Dr. Muhammad Sada, Professor of Cardiology, Alexandria, and Dr. Mustafa Alwani, Lecturer of Cardiology, and our team, Muhammad, Ahmed, Mona, Abdurrahman, everybody is, and then the technical support is doing this. Actually, you asked Habib asked me to have a case of bifurcation complex. So unfortunately, I didn't find a simple bifurcation all finished, but this is the case prepared for you. Distal left main bifurcation. It's going to be presented by Dr. Mustafa Alwani.
Good evening, dear professors and colleagues. Our case today entitled Distal Left Main Bifurcation Lesion. Our patient today is a male patient. He's 58 years old. He is 175 centimeter tall with a weight of 80 kilograms and a body mass index of 26.1, so he's overweight. He has insulin-dependent diabetes mellitus, hypertension, and dyslipidemia, and he's leading an active lifestyle. He presented to our clinic with an effort angina class 3. His lab investigations were normal, except that he has uncontrolled diabetes mellitus with a slight elevation of, an elevation of the LDL cholesterol. We sent the patient for a treadmill exercise stress ECG, which was positive with horizontal depressions involving the precordial leads. His echocardiography has a good ejection fraction of 60% with no regional wall motion abnormalities. And here's the angiography. Okay, in this view, we can see the left main has a 50% distal lesion at the bifurcation with LAD and LCX, and maybe the OM is an early OM rather than being a ramus intermedius. The distal left main shows a 50% lesion. The LED is long vessel reaching the LV apex with ostial to proximal tight 90% stenosis with distal multiple atheromatous non-significant plaque. The LCX is shows proximal non-significant atheroma around 30 to 40%, which will be further clarified with IVUS. The RCA is next. Okay, next. Okay, the RCA is let's say it's a dominant vessel with no significant lesion. Here is the risk evaluation, shows that Euroscore 2 is 0.71%. The angiographic syntax score is 21. In syntax score 2, in case of PCI, the PCI 4-year mortality is 4.2%, while the CABG 4-year mortality is 4.8%. So it's not a significant difference. Okay.
Okay. So because of this case from insurance, actually the heart team was sent for surgery. You know, he's diabetic patient, and the syntax score is more than 22 and less than 33. But actually, this is 2AB if you go for PCI. So we decided, and the patient preference to have PCI, and then I bring this patient insurance to be sponsored by the ICC and another company, with the Abbott company, an Egyptian company, for this patient. Before off air, we do. Can you show us what's going? Before air, this is. I did the diagnostic today also to repeat, and this is the guiding catheters, as you can see in the spider view. 2 wires, 2 BMW wires, one.
Oh, Mohammed, can you tell us what your strategy will be? I mean, what's your plan? And
okay, I'm going to ask you, whether to do as my strategy is to have a guiding, put 2 wires, and use an IVUS. Fortunately, we have an IVUS here in ICC, or they're using. I'm going to use the IVUS to see the plaque burden in the distal left main and maybe the ostial CX, because in angiographically it's shown only in the LAD and the distal left main, and I'm not sure the ostial CX to be involved with notes, so it's 110. So either to do a provisional stenting or 2-stent technique, depending on the IVUS findings. And so off air, we put the 2 wires and then do IVUS. Dr. Rusada is going to explain to you what we saw in the IVUS, and then we take your opinion about what we're going to do, and we stop over this. Dr. Rusada.
Good evening, everybody. I think here IVUS analysis of the ostium of the
you see the IVUS?
left circumflex.
no.
Okay, this
Yes,
now.
we see it now.
So ostium of the L circumflex here, by analysis of IVUS, showed that we have non-significant stenosis, but we have a significant plaque from 3 to 6, as you can see here. And most of the plaque is a little bit fibrous plaque. There is no heavy calcification, which gives us a good opportunity to do a crossover technique of the left main LAD without fear of the marked plaque shift to the ostium of the LCX. Also, we did an IVAS for the LED left main. And as you can see also in this run of IVAS, we have the minimal lumen diameter of the LED is around 3.6 and the left main around 4.1. So our strategy now, as Dr. Sobhi said, to do PCI left main LED, and this by IVAS it should be 3.5 according to the proximal LED. Then we will do upgrade of the left main by 4 or 4.0 according to the result of the initial stenting. So Dr. Sobhi, in this case, would you prefer to do pre-dilatation first?
Can I ask, Sobhi, can I ask Ziad what would be his strategy in this case?
Yes, this is actually quite a complex case. I can see, for example, that the circ, you can call it not significant, but it already has a 50% osteal lesion, which is likely to become worse. So this is something that we have to keep in mind. And then you have a small OM, and then you have a diagonal. You're going to land the stent in the LAD, in the covering the diagonal. The diagonal from the pictures you showed does not seem to be involved. So what I would do is to do this crossover from left main to LAD and provisional for all the branches, really, including the circumflex, which is the main one.
Can you give us more views to see the ostium of the diagonal, Sobhi? We didn't see the diagonal. It's a big vessel.
The IVAS or the angiographic?
No, the angiographic. It's a big diagonal, actually. So.
Yes, I'm trying now to negotiate the diagonal. Yes, because actually we saw it, so we're trying to do some form of. Sorry.
Yeah, we need to see the fluoro instead of the IVAS.
Yes. Yeah, we need to see the fluoro, maybe an RAO cranial or epicranial or something that we can see, or even the spider. We can see the ostium.
ممكن توريهم الأوستيوم.
What do you think, Dr. Batir? Dr. Qais, what do you think?
I agree that the problem of the diagonal will be a problem because it's in the landing zone of the stent when going to the LAD. So we have to see the takeoff of the diagonal, and I think that angiographically, really the circ is really intermediate, but maybe she needs any care and just maybe to do Diga crush for the left main.
Can you have a picture?
But the IVAS is really better than the angio view.
Okay. Now I negotiate the diagonal, as you can see. So I have 3 wires, one in diagonal, one LAD, one in the circumflex. My question to the panelists, are you going to pre-dilate the LAD or not? Because Mohammed is saying that the question to me, I prefer to do pre-dilatation, do it 1-1-1, and then because this is the LAD left main, and so I have to have a lesion preparation, and then I take a stent. Then you ask the second question, the length of the stent, what do you prefer? For you, this is my question.
Can I ask Dr. Nazim is with us? Dr. Nazim.
Really nice case. And as you can see, we are now dealing with 2 bifurcation. At the level of the left main, we have the circumflex and we have the diagonal. I agree with the point of view to go first with the provisional strategy, and I totally agree with the option of pre-dilatation. When you pre-dilate, especially when we're talking about the ostium of the LAD, the ostium lesion are like we could see in the IVAS, it could be a problem at that point. And pre-dilatation, we will give us the ability to inject and have a good positioning of our stent, especially considering that we have a second bifurcation after the left main.
Yeah, I think pre-dilatation is a must here. It's not an option. You have to pre-dilate in osteal lesions, and it will give you also an idea about the plaque shift and everything. So pre-dilatation.
It's the pre-dilatation for the LAD is a must. I agree. But the pre-dilatation for the side branch, which is the circ here, is kind of questionable. The data does not support upfront pre-dilatation unless you're planning upfront 2 stents. So the dilatation for the LAD, 100% you have to do it. But to pre-dilate the circ, the evidence will not support that.
Muhammad, what's the length and the size of this balloon?
I'm showing to you now. I'll just pre-dilate. Can you show me, please, the landing zone of the balloon, please? Open. On screen. This is, I will show you in angio Ziad now. Give me an angiogram, angio shot, please. This is 20 for the LED. And we have just maybe 10 or 13 for the left main again. So do you advise me to take 33 stent for the LED left main? I'm ready for 33, 3.5 because the I was saying 3.5, 3.6. So my advice to take 3.5, 33, and then pot by 4 in the left main, and then see what's going with the plaque shift again.
Yeah, I mean, you want to cover the ostium of the left main. So it's likely that you're going to end up a bit more distal than the diagonal, but that's okay because the LAD there is healthy enough to accommodate this. What stent are you going to start with? What size?
Zine 3.5, 33.
Yeah, I think that's a good choice.
Zine Sierra. This is Zine Sierra, as you know, Ziad, Adil. Usually I prefer 2 or 3 stents for the left main LED because of the trial. I'm just speaking with Habib yesterday about the Excel trial and what's against 5 years follow-up of the Excel and 5 years of Nobel, but in favor of Excel with the periprocedial myocardial infarction, though Excel is the best. So this is an Excel artery, and so I prefer 33 Zines artery. And it could be also this just last meeting, TST Connect was told 1 month depth. You can make it for 28 to 90 days for the Ewing depth for this patient as well.
Because even if you're not covering the ostium of the left main, you should have enough length for the non-compliant balloon, so that you can do a proper pot to the left main circumflex. So I think you should use a long stent. Yeah,
But Adil, you think he's gonna cover? Yeah, you would cover the ostium of the left main.
Of course, because the left main is not that long.
Yes.
So you should cover the left main and up to the ostium.
Yes.
Yes. So now you need a view to see the left main correctly. Dr. Awad will tell you probably 20/20, 20 LAO, 20 cranial.
20/20, please. Okay, 20/20.
Yeah, I usually use 10/10.
10/10 or 20/20?
Do 10/10, 10 LAO, 10 cranial.
10 LAO, 10 cranial. Just go RAO codal and then LAO. Test. This is just a space here.
The important thing is to take your time. You're not in a rush to put a stent in the left main till you are sure you are in the right position.
Okay. 20/20 or 10/10?
Do 10 LAO, 10 cranial.
Okay.
And then we'll see. But it's very important to see the ostium very well.
Yes. Yes. Not cover the ostium. The ostium should be this.
You need to see the cusp with it, so you need to maybe come back with the guider a little bit.
I'm going out to the guiding now. Yes, Surah.
So you see here, this is a good view for the ostium.
Yeah.
Then you need to cover the top well. So I would probably
go back a little bit.
Yeah.
Okay.
Yeah. Few millimeters. Yeah.
Test again. Yes. You know, we have also 3 dynamics here, as you can see. Can we have a picture of the seat? You know, this is dynamic 3D. Yes. Yes. Give this picture.
No, we are fine.
I think you are fine. We can show it also the 3 dynamic.
You not cover the top of the vessel of the left main.
Not yet.
Yeah.
You need me to make it back.
Yeah.
Again? Okay.
Yeah.
A little bit back. Okay, I'll go with you. Okay. Again, please. Okay. Guiding out. بس هجيب
يلا صورة
يلا. I think I'm in the aorta now.
يلا بينا كده we are fine.
And again, everybody is agreed about this position now. Did you see it well? Assume the dynamic and here. Yes, okay. Let's go.
سكرين على سكرين معلش سكرين.
Screen.
تست أخير.
Test. Last shot. Okay, go ahead.
I think it's okay.
4,
What do you think?
6,
Yeah, it's okay, right?
8. أنا برا. 8, 20, 20. Okay, Gonzori. Have the guiding guy. The 2 I can 20.
The length of the stent is well chosen.
Yeah.
ثانية واحدة.
We could. Yes, okay.
ثانية واحدة. صورة. هات stand boost بقى.
We have here a stand boost, so we can look for the stand boost before doing an IVAS or not. Sometimes helpful to stand boost, stand enhancement. Can you give me a
short? 20?
I will show the stand boost now.
How high did you go?
20.
16 atmosphere دكتور زياد.
16.
Very good.
It will be a good test for stand boost, huh? We do stand boost and IVAS, so we know.
We show also what's known as stent acquisition. So now we have a stent boost. We go back to the spider view to show stent acquisition. Can you show us stent acquisition, Ahmed?
Dr. Nazim, how often you use IVAS in your cath lab?
Yeah.
Our cath lab, to be honest, because it's expensive advice, we don't
زود الحقنا سنة. خليك 10-5.
Could say maybe at maximum 1 a month sometimes. In fact, we use IVAS mainly for stent thrombosis, and sometimes when you have a particular for example, when you have trifurcation, you know that
Okay.
but it's not something that we use
لا أنا أجيب واير جديد.
like regularly.
ممكن واير diagonal.
Just as we
that's the situation. Qais, the situation in Tunis the same.
ممكن نسحب الواير بتاع الدياجونال.
كده هنسحب بس.
امسك انت الأول امسك دول.
Yes, we are not using a lot of IVAS, especially in my gut lab. I have no IVAS, but in some university centers we have it, and but use it really less than
سكرين أحمد.
5%, less than 2%.
أنا هسحب الواير أنت خليك مسك
Ziad is our expert, so he can tell us what's his rate in Beirut. What's the rate of IVAS in your cases?
Very low. Very low. You know, because we have because of the financial situation.
استنى شوف.
And we have learned a lot of lessons from the studies by IVAS that you have to pupils dilate and you know the diameter from the LED and circumference. So I think
yes, you're right. So now as
صح 12 اوكي؟
Okay.
مش 10.
Now Adil Ziad, we have now starting to do a pot because there's a plaque shift here. So we do pot for the left main.
So you remove the
I remove the wire diagonal. I remove the wire diagonal because already it's not.
So the diagonal is not compromised, but the circ
is compromised.
It's compromised. Better to do a pot before you recross.
Yes,
I mean,
yes.
Adil, what do you think if you want to ask the panelists?
Yes, whatever, if you are going to recross, you have to pot first so that you will not go under the struts.
Yes.
So pot is essential not only because it might improve the situation a little bit, but it also will make you sure that the other wires you're going to use will not go under the struts.
Yes, I think Adil, what you said is extremely important. We always have to keep that in mind. So what size balloon are you using to pot?
412.
412. And this stent you use can go up easily to 5.5 if you need, ultimately. But of course,
stand boost.
The trick here is to do it on the stand boost itself. So I have to make it with the wire. So I have to be here in the wire. Yes, I'm in the lead now, so I go back. Back. Test, please. Test. Go. Okay.
Yeah, this is the beauty of covering all the way to the ostium.
Yeah.
Now it gives you the liberty
Yeah.
with the length of the balloon you're using for the bot. If you had stopped shorter of the ostium of the left main, you would have had a problem to get the balloon for the bot. But now you can go all the way out to the aorta because you had it covered.
Actually, this is very important what Sobhi is showing us, that the marker of the balloon should be at the distal edge of bifurcation, not at the proximal, so that we'll have opening of the struts to the side branch. This is very important.
الذكرنا the distal point must be in the yeah.
The distal point of the
It depends on the manufacturer. Some markers are ahead, and some markers are so you have to know your balloon where the marker is.
But all the new generation balloons, it's a very short distance from the marker.
You think you covered the ostium with that, with the inflation?
Yes. I make it is 12. I took the near the ostium. But now I have to recross. This is I prefer to do a new wire. Already I took the wire with diagonal. Already open. So I try to open to enter here. أشوف يا جماعة.
بس خلاص.
It's okay. It's okay. Fast easily here. So this is the wire of new wire circumflex.
What kind of wire, Muhammad?
It's BMW wire.
Yeah.
So now, obviously, the crossing distal is, I mean, it crossed very well.
Fresh balloon.
In my mind, it's perfect. It's.
So
what will be the next step, Sobhi? IVUS or kissing balloon? What will you do?
I will open the struts with a fresh balloon, and then we'll go with the IVUS. If there is still plaque burden, significant, so I will do stenting for the short stent for the circumflex. If it is mild, so I be an ending with the kissing, just kissing. For both. Or it's another option. You can make it kissing and see what's after kissing. Whatever you want. What do you think, Adil and Ziad?
Still, there is this both side bot.
No.
Both side pot is a good idea. Yes, I agree.
Okay.
Both side pot.
I'm always doing pot side.
Ah, yes.
Probably.
So you did the pot, do the side, and then redo the pot, and then
okay.
In the left main, maybe I prefer the kissing than the side pot.
You have some residual stenosis in proximal LAD, and kissing balloon with a non-compliant balloon is recommended here.
Stent boost.
What size balloon is this, Muhammad?
This 215. It's 215. Just open the struts.
212.
Oh, 212. 212 to open the struts. Yes. As you can see in the. Can you show? Can you show us the stent boost?
Compliant or non-compliant?
It's compliant. Yeah.
Good.
Yeah. Okay. Deflate. Just open it.
It's easier to cross with the compliant balloon.
طب انا اجيب ممكن بقى 3.5 شورت بالون عندك
عايز تعمل كيسنج ولا
عايز تعمل كيسنج هعمل كيسنج او do kissing rather than then IVUS after kissing.
Okay. Yes. So you're gonna. I heard you say the stent, the circ with the 3.5 you're gonna do, or
what do you think? 3.5 short, 3.5-15 for example.
3.5 or 3.0? Can you show us
3.0?
3.0?
Yeah, I think
3.5. This 3.0, 3.5. But
show us a picture. Show us
the picture. Can you give us a picture, please? Picture again. A new picture here, and decide which balloon. 3.5, I think.
Why do you decide the stenting? Why? It was an ostial lesion that was corrected by kissing or whatever. So why do you put a stent here?
I asked you before. to do IVAS to show the stent or not, or you said no, we need kissing? Yeah. Huh?
The diameter of the circ, the diameter of circ is 3.4, perhaps 3.5.
So a short 3.5, 15.
يعمل ايفاس للاوستيوم سير.
Can I have a vote from the panel? Would you extend the circumference or just provisional?
Dr. Adel, we are going to do an IVAS for the ostium of the LCX.
We have IVAS on board. So if you allow me, just use the IVAS now, just to explain and see the decision. Finally, put a stent or kissing.
And three, there is a dissection in the this ostium plaque shift.
Already have IVAS. You have a cast, IVAS cast. So I can use it now, can use it after. We have still we have 15 minutes more.
So you just be careful when you introduce your IVAS because you only dilated with a 2mm balloon.
Yes.
So just make sure if you get caught, don't force it.
Because we did the side only.
Yeah.
Okay.
I think I would have done that after the kissing. Really.
Okay.
Flowers? What you saying? We didn't hear you.
I think I will go for the IVAS only after the kissing. I want to make sure that the struts are well opposed and the side branch.
It's open. It's very simple. No, it's closed. It's closed now. Okay. Don't worry. Okay.
It was a 2.25 that reached 2.5 or something. So it's the IVAS will pass.
We show the IVAS now.
Shift the IVAS.
Automatic IVAS here. هلا هم بشوفوا هنا.
ماشي.
مانيوال؟
اسحبه مانيوال. استنى.
اوكي.
على سكرين بقى. عندك يا محمد؟
اوكي.
سكرين بص عندك انت يا محمد.
Can you show us the IVAS please here? Yes, okay.
Yes.
So the IVAS caster here in the lesion of the ostium of the LCX. Can you see it now?
Yes. And now we see the plaque in the ostium.
Yeah.
That's the ostial plaque.
Can you measure the area here or?
That's the left main stent.
Now we are in the left main.
Left main now. محمد عايزين نقيس area of the circumflex. The ostium خلاص الIVAS out.
The ostium seems undersized or what? What do you think? Can you give us?
مش مفتوحة.
The ostium of the left main.
Yeah, Muhammad. He is going to measure it. He's going to remove the IVAS caster.
4mm vessel actually.
Yeah, it's a big one.
But I would still take a 3.5 because it's going to grow.
In my point of view, Dr. Ziad, can we take a vote? Who are in favor of doing TAP for this LCX?
You know, it's a big LCX. There is quite a bit of. You just demonstrated right now here that there is quite a bit of plaque. I would do TAP, but start with kissing, and then kissing balloon, and then introduce your stent.
طب أنا يعني I think إن إحنا we already have 50% lesion, and we open this arch and still there is a plaque in the circumflex.
Yeah.
But I think it's wise now to put a short stent of the circumflex.
Who are in favor to do
kissing or stent? Now, can you vote for the panel?
Yeah, I will take the vote now, Doctor. I say to leave it as it is. For my opinion, Ziad says to put a stent. What about you guys?
I think we have to put a stent.
I leave it.
You leave it. So it's 2x2. Where is it, Drisi? Dr. Drisi. And Dr. Nazim, what's your vote?
Here in this situation, a kissing would be mandatory, especially considering the rigidity of the ostium of the LAD. A kissing, and after that, see
one back.
That's kissing.
Okay. Dr. Drisi is with us now or not? No.
Okay, yeah, I'm here.
Yeah, you're here. Okay. Oh, okay, Dr. Najah. What do you think?
To put an stand to in our experience, I think that the long-term will be restenosis and the ostium of circumflexus be very important.
Pretty high.
I think that's
If you put a stent or if you don't put a stent?
I put a stent, yes.
Put a stent.
So
Okay.
how many agree with stenting? How many?
You need to stand. You need to stand because proximal circumflex was very yeah.
So to make a compromise, Sobhi, can you do a kissing first and then we decide?
Yes, Adel, I think this is a good plan because you can. I mean, you cannot. Even if you want to leave it, you cannot leave it with a 2O balloon.
I think it's a stent. It's stenting.
So do the kissing. You need to.
3.5 16 بص فيها هنا انجليزي.
Sobhi decided to stent.
انا decided to stent من السبايدر فيو. سبايدر فيو عشان كده محمد صدقه ومصطفى علواني to do kissing. بس هنا نعم.
Dr. Sobhi, in the instant you have 3.25 if you want.
Yes, we have 3.35.
3.25, yeah.
But the IVUS showed it. How big was it on IVUS?
It's 5 millimeters. According to the IVUS, it's 4 millimeter vessel with minimal human diameter around 4. 5.3, as you can see in the IVUS.
Okay.
I would take a 3.5 and then it's going to
3.5, yeah.
Even Dr. Sadaga is not convinced.
Can you show the audience, not the panelists, the step-by-step for tap technique?
Yes, I will show you now. And now already we have a first spot, then recross, and then we put the stent in the side branch, and then we should put a balloon, compliant balloon at 3.5, for example, in the LED, and then we deploy the stent with a minimal protrusion. I will show you the minimal protrusion in the stent booth now, and then make what's known as back shot balloon, just 4-6 atmosphere in the balloon in the LED. To deploy the stent in the circumflex while you are ballooning LED. Now it goes freely. البالونه بقى.
خليها باركينج هنا بقى ثانيه واحده.
I will park the stand down and then we put the non-compliant balloon in the LED. يلا non-compliant balloon.
You have a 7 French guider.
Yes, this is 7 French.
Excellent. It's so much easier.
Yes. I was hesitating at the beginning to do it for you, radial and 6 French, but because this is a live case, so I decided to make it 7 femoral original and 7 and 2 because it's easy and twisted. That's why I make it easy. Make life
But
easy
you
for us.
see, with the balloon, if the proximal shaft of your balloon is 1.8 French, like the Maverick 2, it's easily done with the 6 French. If you get the proximal shaft of the balloon, not the stent. This is from my experience that the balloon will, the 6 French guide will accommodate
Yes.
balloon. If it is,
and most of the cases I do with 6 French, not the 7, but because of the live, I'm afraid something happened during the live, so it's make it easier to make it 7. Next time I will live in a box for you and 6 French. Don't worry.
And to put, you're going to put 3 wires and maybe 2 stents or 2 balloons. It's better to use 7 French.
Now the balloon is coming.
but you lose you lose the radiant.
عادل, the balloon is coming to the LED.
خلاص عادل خلاص. ارجع بقى تاني.
I can see.
هنرجع بقى تاني ننور.
Okay. Now we have to see the balloon here.
Much nicer.
And put the stent here. And then the stent here. Can you show us stent boost please?
مش هينفع معاك.
عشان البالونه مش هتيجي.
خد صورة من غير سوا.
صورة من غير سوا. Okay. Did you see the minimal protrusion of the stent?
You can use the shaft of the balloon as a marker, right?
Yes.
You want to do a little injection or?
Can you test these? Yes. Okay. Do you agree?
لا spider لا.
Or you make another view. You can take a spider view as well.
Spider view, yeah.
Spider view.
Shallow spider.
Spider, but then برضه test please. Test.
Dr. Awad telling you to pull back the balloon and the LED. It's a little bit.
Okay. Yes, you are right. Agree يا دكتور عوض كده؟
تمام.
اوكي تمام حبيبي.
تمام.
يلا.
لازم دكتور عوض يبقى مبسوط خلي بالك.
لا ده هو عنده محاضرة تقيلة بعد كده.
خلي بالك.
ما اقدرش. دخلني السودان مش هدخلني السودان يلا. Let's go. The step now is to deploy the stent. يلا انجل. in circumflex.
Okay.
And then 4 atmosphere here. And then 4 atmosphere.
It seems to be nice.
6. Then here 8. 8. And 15. 20 here in the LED. Then 14 LED. 14.
Why don't you go back a little bit with the balloon?
Yes, I will go back.
The important thing in the tap technique is to inflate the side branch first.
Yes.
And then inflate the main branch.
Okay.
And you deflate them together, no problem.
You must cover just the struts of the main stand because the protrusion in the left main perhaps can be lead to restenosis in few months.
Yeah, right.
Okay. I just protruded the balloon.
Tell us what is the size of the
inside. Did you see what I'm doing now?
Yeah, you go back a little bit, yes.
Okay, then a picture without dye to see the stance both. And then we do simultaneous. One higher, one lower, and then one higher, one lower, and then the same pressure, 14 both.
The rule is to inflate the side branch
first. And then
you deflate them together, but inflate the side branch first in order not to crush it by the
Number one, the side branch with higher pressure, with a low pressure on the beam, and then higher, lower, and then you attain both 14, 16, and then wow. Sometimes you do repot of the main vessel, but I don't like it. This is a tap. This is common in DK crush, not in tap. Okay. Can you stand boost? Stand boost first. We can try. Can try stand boost with both.
Can you show us the boost?
Did you show us? Can you show us stand boost, please? Stand boost, please, in the screen to them. Ahmed Yusri, stand boost, please.
You know what you said there, Subhi, but the proximal pot is very important. Proximal pot is important.
Yeah, he will finish.
One.
Yeah, but you have to be very careful
not to crush.
Yes, not to get into the bifurcation.
It depends on the length of the left main.
No, you can go out. You can go out.
Yeah, you can go out.
Yes, I'm out now with the balloon, but the wire is inside. And then I do injection and see if you want for me to do an IBAS again for PCI optimization.
I think Subhi, it's time. You have 3 minutes left.
Okay. So I give you just 3 pot for the LED. I give you a picture now. Picture,
yeah.
Okay. Give me spider, please. Spider. وبعدين
بص انا عايزك بس تست واير الليد تعرفي واير الليد.
اوكي.
شوف مين بيتسحب.
And the first marginal is still alive with a little pinch, but everything looks fine.
Everything is fine.
You will still need to do an osteal pot, just osteal.
شوف مين فيهم هيتسحب بتاع الليد.
Yeah, it's very serious if you go inside. So try to be outside from the ostium, just as Dr. Ziad said. Just pot
to avoid
we are going to repot now for the LED, left main.
Yeah,
then say goodbye to you. Yes, outside the carina, maybe the ostium, and then say goodbye to you.
Professor Sabhi, don't care about the time. Take your time to optimize.
Okay, I just the PCI optimization because we have started 5 minutes.
As I heard from Dr. Habib that there is a live transmission next to your session. So, Dr. Awad, what's your duration of your talk?
Would be 10, 12 minutes max.
10, 12 minutes. Okay.
Okay, so we have time.
معلش اسحب الواير يا بيه ثواني
Circumference.
اسحب واير السيرك
So you have 3 minutes more.
يلا جرب تخش تاني
Okay. Our new balloon. Okay.
بس خلاص
It passed here.
ستاند بوست بقى من
Stand
فضلك
boost, please. This is the final.
I think you should go back.
Okay. I'm saying it with that stand boost.
ارجع ورا تاني بقى
You need to inject
ستاند بوست تاني
لا استنى من هنا ومن هنا.
let you know where the circumflex is.
Yes. Yes.
Injection, please.
تيست بقى
Test.
بس انا كده ام فاين يلا بينا
Okay. I'm outside the circumference.
Can you go back a little bit?
Yeah.
Yes. First one, and then go back. Okay. Deflate.
انت اصلا بروكسيمال ديفورم خد بالك عايزين نعملها تاني ارفع في
I will
الجايدنج
go
ورا
out with the
شويه
guiding. Okay. يلا. Yeah. 20, 24, 25. Deflate. Stand boost again.
ستاند بوست تاني بقى واحنا
Stand
في
boost
نفس
please
الوضع ده
before the injection.
هات لو كرينيال من فضلك
Okay, excellent. Again.
Beautiful. This is beautiful. You see the balloon is away from the new carina.
I give another عشان this is for Ziad.
سالونا ورا شويه كمان
This is for only Ziad.
ورا كمان
10
يلا هات
My friend Ziad from Emory.
اي والله يا محمد.
حبيبي. يلا okay.
نظر هطلع بقى واحده
يلا
ثانيه
20, 22.
Oh, very nice. Very nice.
Okay. Deflate. Stand boost final and then final shot and then okay.
بس اهم حاجه وانت بقى
I know.
تفتكر اللغمه اللي الجاي عشان ما تعملش تروما
The trick for for the left main as well, you have to do the guiding out and then put the balloon in and then out. Again, also for the wire should be the guiding out, otherwise we decompression with the guiding, longitudinal compression. So it's very,
Another
very
important trick is always when you advance the guiding, advance it on a balloon, not on the wire.
Yes.
Otherwise, it will distort the partial left main.
Absolutely. Yeah.
Okay. Spider final shot.
وبعدين
Okay.
تراو كودل بقى
Go out to the wire. Okay.
All right.
Nice. Nice. All right. Excellent.
Thank you very much, my colleagues. I'd like to thank all the Pafcic 2020, the Habib and his group, and also the panelists, my friends, Adil, Awad, Ziad, and Beit, and all my colleagues, Dr. Sada, Dr. Alwani, Muhammad, Ahmed, Abrahman, everybody here in Mona, all my colleagues here. Okay, and the patient wants to say something. Okay, are you okay? Okay. Goodbye. Have a nice meeting.
Thank you very much, Ahmed.
Bye.
Very nice case.
Bye. Thank you for help.
تسلم ايدك يا بيه جميل.
All right.
Okay.
Dr. Awad, are you ready for your talk?
Yeah, thank you very much, Adil and Habib and Yad and all the panelists. Thank you, Pafcic, for this opportunity. I think you have seen...
You have exactly 12 minutes.
Okay, you have seen masters at work. Like all the technique and left main stenting all went very well. I just going to go through highlights of what is stenting of complex bifurcation is all about. Let me just start my screen sharing. Can you see my screen now?
Yeah.
Okay, so...
No, we can't see it. We can't see the ICC now.
Yeah, you can see my screen now?
No.
ICC need to unshare.
صبحي. It's the job of the IT that should interfere now.
Can you hear us, Habib? Can you ask them to?
Yeah.
Yes, I'm calling them, so don't worry about that.
Okay. So this time is not on my own time, huh?
Harun, can you
Yes.
share the screen and give Professor Awad to?
دي حاجات deliberate يا عواد.
جربة يا قيس، جربة قصت علينا البث يا قيس.
Yeah. It's not me. Harun?
Oui.
We must unshare the Alex.
Yes, he just need to share his screen. I don't have them.
Okay. So, Professor Awad, you can share your screen.
Yeah, I'm sharing it. Share screen.
You just have to share your screen, please.
Yeah, it's coming up. Can you see it now?
Yes. Yeah.
Yeah.
Can you see
Okay.
my presentation?
Yes. Finally.
Very well.
You have
Very
3
good.
minutes.
And now you have only 9 minutes. Sorry.
We can't hear you, Dr. Awad.
Awad, we cannot hear you. You have to activate the sound.
I think it's the connection. It's the connection.
Activate your camera.
So Awad, if you're hearing us, I think you have to turn off your connection and connect again.
Habib, he had his chance, Habib. He had his chance. This is the...
Yes. Awad, I'll try him to call him on WhatsApp.
This is, I think, a Wi-Fi problem, maybe. Don't know.
Habib.
Yes. Yeah, Fawzi.
In the logo
He's
of...
not answering the phone, so it must be a problem of connection or something like that. Yeah, Fawzi, go ahead.
Yeah. In the logo of Sudan Heart Society, the coronary artery of the Sudan was the Nile.
Mm-hmm. Yes.
Nile, yeah.
Yeah.
Nile in the heart, yeah.
Right, good observation.
Yeah. The Nile of the heart, right.
So waiting for...
So did you agree about the use of the IVUS in this case, in the life case, really?
Yes.
Because it was only an intravascular imaging just to decide if we have to stand.
Can you hear me?
I said it.
Yeah.
Okay.
Yeah, we hear you.
It says you cannot start sharing while other participants are sharing.
I think in this cases.
Somebody else is sharing.
Try to share now. Try to share now.
Okay. So can you see it now?
Yeah, we can see you and we can hear you.
Yes,
Yeah,
finally.
Okay. So I just go back. Go back one extent. This is the Medina classification. Alfonso Medina gave us that. One referring to main vessel, distal main vessel, and the side branch as 1-1. And Then, to be able to talk the same language, you need to know what angle we're talking about. Different angles have different specification. It helps you in choosing your strategy and what type of two stents up front or provisional stenting, depending on the angle. You have to choose the views you need to address the side branch with, because in this view you see the ostium of this side branch looks normal, but the same artery looks completely different in a different view. So you have to study your angiogram very well before you embark into this adventure. You have to look at the pictures very well. Is the side branch significant? When is the side branch significant? I think any side branch is significant. You do not want to lose a side branch. You might choose a simple approach to it, one stent, but you cannot afford to lose a side branch. This is what all bifurcation is all about. But arbitrarily defined as a big branch, more than 5 millimeter lengths of disease. And this again depends on what patient. This patient might be recovering from acute myocardial infarction. His part of myocardium is already jeopardized. You do not want to add insult to injury by occluding another branch going to a viable area. So it's not only the size of the side branch you need to worry about, it's the whole setup of the patient. So now you know that this branch is significant. What are the problems? The side branch outcomes, the first thing is you stent across the branch, you get blood, you get carina shift. This is because the first principle, you have to stent according to the size of the distal artery, not the proximal. If you do that, you're going to move this. This is called the carina shift. It's not only the carina shift that causes you a problem. This is well documented. It is once after stenting, if the gel side branch is compromised, this is called the carina shifting. It's carina shifting plus black shifting. Black shifting is shuffling the stuff in the main vessel as you inflate the balloon into the side branch. So the combination of two, the carina shift and black shift, what causes side branch occlusion. But it's not that all bad news. If you see the nipping after stenting, that does not mean this side branch is compromised. This has been shown time and again in different studies where they look at angiography. This is angiography. This is what your eyes are telling you. This artery is occluded 70%, 80%, 90%, and this is FFR. Anything lower than 75 is significant. If you look at that, most of the lesions where your eyes tell you this is significant lesion, when you do the FFR, it is not significant, most of them. So do not let your eyes deceive you. When this narrowing is there, does not mean the artery is actually compromised. Two major studies have shown that, by Curtis in England and in Korea, and the conclusion in both studies that most side branch lesions do not have functional significance after stent implantation in the main vessel. Quantitative coronary angiography unreliable in assessing the functional severity of these lesions. So we want to keep it to single stent. If you do that, you're going to see the nipping, but the nipping does not necessarily mean the artery is compromised. This has been well studied. And this gentleman said, keep it simple, make everything simple as possible, but not simpler. You do not want to take the side branch lightly. Bifurcation intervention in school is all about saving the side branch. It's not a matter of shoveling only single stent, make a quick job and go. Provisional stenting is not about single stent. is stenting the main vessel first, and then see what you want to do, like just like Muhammad Subhi and Muhammad Sadaqa did. They stented, their intention was to put one stent, but when they came to go home, they found out the ostium of the circ is compromised, and then they put the second stent. This is what provisional stenting is all about. Why? The guidelines tells us, the green box here, that is the must. You have to do what these people agreed on, that is stent implantation in the main vessel only, followed by provisional ballooning. This is what they were discussing just now, kissing or not kissing or pot, and then after that you see what you want to do. So this is the recommendation. Why? Because they found out that occluding the side branch does not go lightly. Do not underestimate the side branch. This is the clinical impact of side branch occlusion. If you occluded the side branch, clinically, MACE is significantly increased, and death. This is very hard, solid endpoints, ladies and gentlemen. You will find reduction. This is survival free from MACE, significantly reduced by the solid line is side branch occlusion. If you occlude the side branch, your MACE is significantly going to be occluded. Death is significantly higher in no side branch, in side branch occlusion. This is 100. So by saving the side branch, you're not only reducing MACE, you're saving lives. So any side branch, you need to strive to keep it open by the end of the procedure. One stent or two stent has been tried even in left main. This is the Ultimaster registry. In yellow is one stent, in gray is two stent, and there is no significant difference between them in a way of target death, target vessel revascularization, whatever you look at it. There is no significant difference. You just need to tailor-made it to what the situation is at the time, as you've just seen on this video. How to do provisional stenting? You have to wire both, and wiring, if you look here, this is the trick I learned from Jerry Revolve. This is called the steering wheel. The steering wheel, once you go into the branch, you do not push. You turn the wire and it will fall into the side branch. This is the first stage in doing it, wiring the main vessel, wiring the side branch, and then you decide. You have to, we're just discussing that, and at the beginning, you have to predilate the main vessel. This is the must. But the question comes with side branch predilatation. There are only two studies in that. One is observational and one is randomized trial. The only randomized trial done by Dr. Pan. Pan is a friend of Alfonso Medina. And when Medina died, the nice paper written by Pan, and he said, today we lost a 111 cardiologist. They were lifelong friends. This is by the by. The predilatation on the left, on the side branch, is not recommended by the European Bifurcation Club. You should not predilate unless you're coming up front for two stent strategy. Why? This is a randomized trial, the only one, predilatation or not predilatation. In the very short term, the predilatation lowers the TIMI 3 flow, is lower in predilatation, the side branch predilatation is lower in the very short term, but in the long term, the side branch dilatation is deleterious because you end up with dissection and you end up putting two stent, which was not your plan to start with. Now, this is the steps how to do it. You wire both, you take your stent according to the distal vessel, you bound to leave this space, and this is trouble. You have to bot. You choose the bot. The bot is the most important invention in the coronary intervention. It was done by Oliver Dermot in 2007. I will show you his actual stent when he presented that for the European Bifurcation Club. And the most important one, you do not want to push the carina this way. You have to be where you're marking it. This is what Prof. Adil Itribi alluded to, and Ziad was talking about. This marker should be here. You want to push this struts to this side and leave this untouched. And the carina is always healthy. It's never involved in disease, and it should remain healthy. And this is how it look. You push the stuff towards this side. This is with the bot. Now you have to recross either with this wire, you pull it back and come in, or you, if you're working in a rich country, not like Sudan, you have to get another wire.
Awad, I'm sorry, I don't want to disturb you, but in LA, they just have a patient on the table. So just if you'd like to...
conclude, yeah.
So I... a little bit. I'm so sorry about that.
All right, okay. So the question came up now, after bot, what do you want to do? Final kissing ballooning, or just do a bot side? But whatever you use, you have to do it first. You finish kissing is what the recommendation are now. But bot side, bot is coming up. There's no yet enough evidence for it, especially in the left main. I will conclude in 2 minutes. So just for the bot, because that was mentioned, these are actual Oliver Dermot slides. You leave this gap. You want this thrust to go up, and you want to close this gap. Whether you use compliant or non-compliant, this is very important. This paper by Mozzarato, he says only compliant balloon can offer an optimal bot, because the bot with non-compliant, here compliant, non-compliant, with the compliant, you can only go to limited number, the semi-compliant. The non-compliant can only give you 4% extra. So you need to know the size before you go. But with the semi-compliant or compliant, you can go 11%. So if you have a target of 3.27, you can take a 3 and take it to 3.36. You cannot do that with the non-compliant. I think the simplicity is the ultimate sophistication, as Leonardo da Vinci said. With that, I rest my case, and thank you very much.
Thank you, Awad. We really would like to thank you very much for this. We wish we could have time to have discussion. You're the bifurcation expert in Africa and beyond, and I hope you'll have the chance of organizing a whole afternoon dedicated to bifurcation, and you will be, of course, our expert and guest. Okay. Thank you guys very much. That was a very interesting live transmission with Mohammed Subhi, and a nice and very clear and teaching lecture on bifurcation by Awad. Thank you again, and I invite you to join the Cedar Sinai live transmission with Raj Makar, and then there will be a mitral valve repair and tricuspid valve replacement. Thank you very much.